Yes.
For the sake of time and to give Dr. Arwater plenty of time, I'm going to transition over to introducing him. And Paul, I will allow you to share your slides, but I will just first say that Dr. Arwater is our clinical director in the Division of Infectious Diseases, a real international leader in COVID-19 and in infectious diseases, and is the Cheryl and Ken Fisher Professor of Medicine here at Johns Hopkins. So I'm going to allow Paul to share. So Paul, I'm going to stop my share and hand it over to you, and hopefully you can share your slides. And again, as there are questions in the chat, our experts, please feel free to try and provide your expertise and answers to our audience.
Thank you so much, Dr. Chatterjee. And I also appreciate all the comments and the therapeutic challenges that our patients face in this pandemic and the stresses that come. Now, I want to make sure, are my slides displaying now? Are my slides showing?
Yep, they are.
Yes, they are.
Okay, wonderful. So in 15 minutes, what I hope to do is go over what I would say are the highlights of COVID-19 therapeutics, and many important points have already been made by panelists and speakers today. Almost all on this call, of course, are aware that the early part of this illness seems to be a typical viral-like phase centered in the respiratory tract with potential dissemination to other organ systems and effects that are then magnified by the host response. And there is information that suggests that the more virus someone has, then the more inflammatory responses are engendered in some people as they try to respond to this infection. Of course, in the patient displayed today had actually gone on to lung injury syndrome, which required a prolonged hospitalization. Now, as many people have already presented, there's an early and a later phase. And of course, many patients do well. They don't go on to progress to need oxygen or hospitalized care. But for me, when I handle my own patients, I try to think, are they requiring oxygen? Are they stable enough to be home? Unfortunately, unlike influenza, we don't have abundant treatments in this early phase, such as oral oseltamivir, to help patients. But here's where antivirals would work. And really, we're only left in this early phase, at least with therapeutics, for antibody-based therapies. To date, this really has centered on monoclonal antibodies that have shown effect. Here's one, casirivimab and endivimab. And there have been a number of studies using this monoclonal cocktail where there is a substantial 70% reduction in people ending up in the hospital or dying. And so this large study of over 4,000 patients, all with risk factors, also had a reduced duration of illness. But this is really a therapeutic that could be employed if it's available, especially in unimmunized patients or patients at high risk. I would point out here that 3 days from symptom onset is when patients receive this antibody. And so again, for early impact on the virus, early administration is best. There's another monoclonal that's actually a single antibody, sotrovimab, that is affecting a very highly conserved area of the receptor binding domain of the spike protein. And although this was a smaller study, also showed a substantial reduction in people ending up in hospital or death, again, having received this on the early side just days after onset. Of course, there's been much discussion about variants, with perhaps the Delta virus being most worrisome across the globe currently. The early antibodies of bamlanivimab, and then subsequently combined with etesivimab, have showed a less activity against some of the variants and really are no longer being used in the United States or distributed. Whereas the two I just mentioned, at least on in vitro pseudo-neutralization assays, still seem to have sufficient activity to help our patients. So if you do have access to these monoclonals, you can consider it for early illness. Obviously, patients at high risk, the elderly, people that are obese, have diabetes, and so on would benefit. Over time, people that don't respond to vaccine well may be another group that may be targeted, such as immunosuppressed. And really, in the United States, the use of these monoclonals have increased dramatically with the rise of the Delta virus. Trials in hospitalized patients have not been effective. Now, as I mentioned, those are the only sort of green light treatments, meaning that I think there's robust clinical evidence to suggest it works. And there are two that may be up and coming. There's still not probably sufficient large studies to show benefit, but inhaled budesonide, which we use for asthma, may have either anti-inflammatory activities or interfere with virus binding. And there was a small study published this spring that suggested that there was less need for heading to an emergency department, urgent care, or hospitalization, and some small improvement. And then the larger principal trial, which came out with a preprint of over 2,000 patients, showed that there was a reduction in 3 days, and but not a trend towards, not a statistically identifiable benefit towards avoiding the hospital. So this is something that might have potential. I think it's been adopted by some of the guidelines in India and in other countries, and is a potential option, but not with strong evidence. Another odd one is this old-fashioned serotonin uptake inhibitor, fluoxamine, which is used mostly now for obsessive compulsive disease. This has some in vitro biologic possibilities of inhibiting inflammation or as an antiviral. And one early study found that no one in the treatment arm actually progressed compared to those in the placebo. And just last week at the NIH, the Together trial was presented, which showed that the group that got fluvoxamine had fewer events, meaning that they ended up in hospital or emergency departments with about a 30% reduction. Again, all waiting for larger trials to probably make this more of a routine treatment. But we really want to help our patients, as other panelists have identified, and use drugs that we have available. But sadly, this doesn't work. And you might ask, why does it work in the test tube? It's because many of these drugs inhibit host cells, and host cells are needed to make new virus. So it looks like all these compounds work, but unfortunately, trials in humans have been largely disappointing. And I just have some selected studies here that really have shown that for early treatment, I would focus on azithromycin, colchicine, favipiravir, and ivermectin really have not shown substantial improvement for patients, and in the case of some could do harm, such as hydroxychloroquine. So I think we have to do no harm to our patients, and giving them something that doesn't work could also give them a false sense of security and keep them at home longer than they should be. What many have already spoken about today that is perhaps a danger to our patients is using dexamethasone or steroids early before people have a significant inflammation or require oxygen. And this information comes from a number of trials. The one I'm showing here is the recovery trial, and the subset in this slide is people that were admitted to hospital not requiring oxygen actually had a trend towards worse outcomes, higher mortality rates. So it's clear that this giving a steroid early here, I think, can be detrimental to our patients, and we should really do our utmost not to give steroids until the proper timing, which so many speakers have commented on today. Also, regarding either high dose steroids or prolonged steroids or early steroids can predispose to secondary infections, especially fungal. So this is something to be on the watch for. And as Dr. Chatterjee mentioned, the dose is really relatively modest here. It seems to be just enough to tamp down inflammation with dexamethasone 6 milligrams rather than high doses. And we'll get back to dexamethasone momentarily. Now, for patients that are getting worse, they need hospitalized care and oxygen. There are really 4 drugs that have sort of come up as routine use based on large or well-done studies. And this is a helpful website at University of Pennsylvania that tends to rank the drugs along with the number of patients, the quality of the trials, and so on and so forth. And we'll briefly touch on all of these 4. Remdesivir has been discussed. I know one panelist has pointed out that it does shorten duration of illness when compared to placebo. This is from a trial now from 2020, early in the year. And this was a placebo trial with a mortality trend, but the people that seemed to benefit most were those that required oxygen. And on average, they got it on their 9th day of illness, which you might argue would be late in the viremic phase. But yet, I think there's still some actions that clearly this influences. But if you're starting it later when someone is on mechanical ventilation, further in the days of illness, as you can see on the right-hand side, there's no benefit. Now, the drug seems to be very safe. In fact, in this trial, remdesivir had fewer side effects than placebo, which probably meant that it was helping moderate the disease. But yet, worldwide, many, especially in Europe and elsewhere, have not used remdesivir based on the Solidarity trial, a large trial that did not have a placebo arm. It was open label and gave the investigators options to switch patient arms. And I think some of us feel like this is probably not the right trial to really prove the worth of an antiviral. So, of course, but this has influenced many to not use remdesivir. And a number of trials here, and this is just a retrospective one, have endorsed or have found at least that there is continued time to better improvement, even in patients that are managed later in the pandemic rather than earlier, as in the Act 1 trial, and a suggestion of mortality benefit. Again, retrospective, but well done here, which I do think speaks to the potential for this. In patients with renal failure, we continue to give the drug. There's a warning against it because of the carrier, the SCED carrier, but we feel it's quite safe to give, and there's experience with this carrier and other drugs giving it in renal failure. And we tend to use it early in the illness, less than 10 days of onset for people on oxygen, for 5 days with an option to extend it further based on some trials if someone progresses to the ICU. Although it might work earlier in illness, we just don't have enough data, and probably because so many people improve on their own, many would have to be treated. One drug that's certainly has fallen out of favor compared to a year ago has been convalescent plasma. In fact, the New England Journal published today another trial in hospitalized patients that did not show benefit. This meta-analysis here has shown, mainly weighted by the recovery trial, a large trial, that there wasn't much benefit, but these are very heterogeneous trials, and often plasma is given very late in administration, meaning day 9, for example, was the average in the recovery trial, which as an antiviral is probably too late. What we do in our hospital is use it in someone that might be immunosuppressed and not capable of mounting antibodies, or if they're on the early side of illness and might be at high risk but hospitalized. One quick mention of the monoclonal antibodies, which I told you studies haven't found that they helped in the hospital, but the recovery trial did publish this as a preprint, which suggested that if patients are admitted to the hospital and seronegative, if they get monoclonal antibodies, there is a reduction in mortality. But I have to note, this is a very high dose, almost 7 times higher than standard dosing at 4 grams and 4 grams. So this hasn't been widely adopted yet and would require probably you testing patients with a rapid return on antibody status. But this is something that may be of interest and you'll hear about more. Lastly, I'll conclude about immunomodulators. You've already heard about dexamethasone. This is really the drug that proved that patients in the ICU benefit with a marked reduction in mortality of almost 40%. But even patients on oxygen also have a benefit of about 18% reduction in mortality. Again, if they're not on oxygen, don't get it. Many people have already talked about pulse steroids or equivalent steroid dosing. These are the doses I think have been widely circulated as equivalent, and with up to a 10-day duration. Of course, as Dr. Chatterjee mentioned, this has to be weighed individually, but you don't want to give too much because it could predispose to secondary infections. Tocilizumab has been discussed. This fell out of favor really when used as monotherapy, but has really come back, and we use it when the patients are progressing despite dexamethasone and remdesivir and look like they might be heading to the ICU, so they're on high flow oxygen or non-invasive non-invasive ventilation, or in the first 24 hours. Here's the key difference though. The 3 trials that turned around its use, I think, and influenced people, these are trials where about 80% or more patients were also on steroids. So it looks like the difference here is that tocilizumab must be used with dexamethasone to get the benefit in terms of either mortality or trying to halt the progression to the need for mechanical ventilation. And then baricitinib, which is perhaps the least widely used of the ones that have benefit in trials, early on was just studied against placebo in the Act 2 trial with a 1-day shortening duration of illness in hospitalized patients. But the Cove Barrier trial, where again, most people were on steroids, interestingly didn't meet its primary endpoint, but its all-cause mortality had a rather impressive reduction in mortality of almost a little over 40%. And I would mention that, again, compared to tocilizumab, there's less data regarding baricitinib, but this is something that I think if you don't have tocilizumab, and there's already some shortages in the United States in areas where many people are in the hospital, baricitinib is now being employed, but it's being used again in combination with dexamethasone. So in conclusion, if I were looking at treating patients, what I feel confident can help my patients are if you can get monoclonal antibodies in patients at high risk who are ambulatory, it can help. That is very clear, I believe. If you're hospitalized but not on oxygen, it would be monoclonal antibodies. If you're needing oxygen, then remdesivir and dexamethasone. If you're getting worse, then that's where tocilizumab or baricitinib may have some benefit. If you're in the ICU, then it's dexamethasone. And if you're in that first 24 hours, perhaps tocilizumab also could have some impact. So I'll turn this back to you, Dr. Chatterjee.
Dr. Auwaerter, thank you so much. That was very informative. Obviously, so much data to work through in such a short amount of time. And as we've mentioned before, there will be a comprehensive document that is emailed out to our registrants with some references for you to look in. But thank you for that very comprehensive, and then some key pearls at the end there. Let me just share my screen one more time here. And I do want to thank all of our panelists and experts. I saw a lot of activity in the chat and very much appreciate you taking the time to both share and disseminate your expertise. We will again provide the follow-up resource as I mentioned before, and then we do have upcoming sessions, COVID-19 and pregnancy, and then palliative care considerations, which I think we all need to consider, particularly during this pandemic and all of the unfortunate illness and death that we're dealing with. Here is the calendar of what is to come. We very much appreciate again, the participants as well as the experts. And our next session, we have 2 great experts, and we love to see our sort of diversity of expertise here, and it's fantastic to have strong female representation, mentors, models, and experts to encourage all of us. So this will be the next session. contact details for our USAID and RISE representatives for those who have questions about how to register or next steps. This is all available. And I want to see, I don't know if Bhakti is still on, but if anybody has any other closing words, I'll give them a chance. It is 9:30, so we'd be brief with that.
No, thank you very much, everybody. We'll see you in about 2 weeks to talk about pregnancy and COVID. In the meantime, if any of the health facilities featured here are curious as to what RISE is doing at health facilities, what trainings we have available, workshops, please reach out to any of the individuals listed here. And we look forward as an organization to work with you.